Under general anesthesia and full relaxation, the patient is placed in a supine position on the operating table. The legs are slightly abducted and lowered and are fixed into the padded receptacles. The arms are also padded and fixed beside the body. A sterile Foley catheter is inserted after skin prep and draping. The left anterior iliac crest. The symphysis pubis. The right anterior iliac crest. The camera trocar incision left midline of the umbilicus. The left 8 mm robotic trocar at the midpoint between the camera port and the iliac crest. The right robotic trocar. The 12 mm assistant trocar craniomedial of the right iliac crest. The 5 mm assistant port is equidistant between the camera and the right robotic port. The ideal distance between the robotic ports and the camera is at least 8 cm. The skin is incised over 2 cm transversely just below and to the left of the umbilicus. With 2 Langenbeck retractors, the anterior rectus fascia is freed from the fatty tissue. The anterior rectus sheet is incised vertically over 1 cm. The 2 Langenbecks divide the rectus muscle and expose the posterior layer of the rectus sheet. The preperitoneal space is then freed by blunt finger dissection. This space is further developed with an inflatable balloon trocar. The balloon is filled by a hand pump until the extraperitoneal space is appropriately created. Balloon dilatation must be performed carefully to avoid bladder ruptures and peritoneal lesions, especially in cases of peritoneal adhesions. The first 8 mm robotic trocar is introduced with a blunt obturator on the left side between the subumbilical incision and the left anterior iliac crest, about 1 cm lower than the camera trocar incision. Then the 12 mm camera trocar is introduced and the insufflation is started with high flow and a maximal intra-abdominal pressure of 12 mm of mercury. The camera incision is closed with a silk suture to reduce gas loss and maintain the intra-abdominal pressure. This incision is necessary at the end of the operation for the removal of the prostate in the specimen bag. An inspection of the extraperitoneal space is performed using the 0-degree optic. The camera can be used under direct vision to increase the size of the extraperitoneal space by gently sweeping the peritoneal borders laterocranially. Gentle pressure of the other hand on the abdomen facilitates this maneuver. The space is expanded by circular movements of the tip of the optic until the second 8 mm robotic trocar can be placed under visual control. Again, pressure of the finger on the abdomen can help in the exact positioning of the trocar. The disposable 12mm assistant trocar is placed just craniomedial of the right anterior iliac crest. The insufflation tubing is transferred to this port so that the cold CO2 is not in direct contact with the optic. This helps reduce fogging during the operation. Finally, the reusable 5mm assistant trocar is placed between the right robotic trocar and the camera trocar as high as possible without puncturing the peritoneum. To assist in this placement, the camera is transferred to the 12mm assistant port, where the visualization of the camera trocar and the 5mm port insertion is possible. Here is the final port placement. At this point, the patient is placed in a moderate Trendelenburg position and the table is lowered as far as possible. The robotic cart is driven in between the patient's abducted and slightly lowered legs. Care must be taken that the arms do not become unsterile, for example on the OR light, which must be moved out of the way. The camera arm is lowered with the correct angle onto the camera trocar and is then fixed by the assistant. The camera is inserted into the arm and an abdominal inspection is performed. The camera arm is used to lift the abdominal wall, creating extra space. If necessary, the camera trocar can be withdrawn slightly at this point, allowing more camera movement. The robotic arms are swung down to the robotic trocars and attached using the screw fittings. The correct placement of the trocar in the abdominal wall is controlled and corrected if necessary. The same again on the left side. The endo-wrist instruments are inserted under visual control. The monopolar scissors on the right side and the bipolar forceps on the left. We use the grasping forceps for the assistant in the medial 5mm port and the suction through the 12mm port. Both cautery cables are connected and the surgeon can take his place at the console. Here you can clearly see the hand movements on the masters of the console and the corresponding movements made by the robotic arms at the patient. We routinely use this extraperitoneal approach as it offers some distinct benefits for the patient. Less Trendelenburg positioning allows better ventilation. Abdominal complications such as intestinal injury, trocar hernia, subileus and intra-abdominal urinoma can be reduced, and it offers open dissection planes even in the case of previous intra-abdominal surgery. This comes at the price of a slightly increased risk of lymphocele. Recently published literature reports equal oncological and functional results, with an overall operating time equal to or shorter than the transperitoneal approach. However, the transperitoneal approach is still preferred in patients needing an extended lymphadenectomy, after previous hernia mesh surgery, or renal transplantation, and where extraperitoneal dilatation is not possible. In our series of the last 152 radical prostatectomies, a transperitoneal approach was chosen in 60 cases and an extraperitoneal approach in 92 cases. Median time to console was 17 minutes in the transperitoneal approach and 20 minutes in the extraperitoneal approach, with an equal median BMI in both groups. Although the transperitoneal approach is still favoured by the majority of robotic teams, in certain circumstances the knowledge of both techniques is an advantage. Therefore, we recommend that centres of robotic expertise should train in the parallel use of both techniques.